Okay, ladies and gentlemen, welcome to my channel, Nursing Education Tutor. My name is Cheryl Spencer. So in this video, I'm going to talk to you about urinary elimination. We have bowel and urinary. So in this video, I'll do urinary, and I'll upload another video soon on bowel elimination. So let's talk about your urine. So let's talk about the process of urination. The process of urination depends on several organs, not the obvious one that people often talk about. So of course it depends definitely on the kidneys. And when we talk about the kidneys, the ureters, and also the renal arch, we're talking about an upper urinary tract. So remember these terms. You may hear a provider refer to a client's issue as they have an upper urinary tract infection as opposed to a lower urinary tract infection, such as in the bladder, the urethra, and the pelvic floor, which are the more common ones. Your cardiovascular system definitely affects how much urine you put out. If your heart is pumping adequately, if you have an adequate cardiac output, stroke volume, the ability of your heart to relax and then contract with a good force will definitely determine how much blood gets to the kidney, and ultimately how much is filtered out through your urinary bladder and through your urethra. Your brain, the nervous system, also plays a role. We talk about, especially when we talk about urine, we talk about your endocrine system. Your body, your brain has a role in thirst, and thirst has a role in how much you drink, and then ultimately how much you put out. So I recommend in any type of system that you're studying, do a brief review of your anatomy and physiology, and it will definitely help you as you understand these processes as you move along in your nursing program. And here I have a quick slide that shows your kidney. Of course, it shows a kidney bean. So the kidney, just remember that, your kidney filters blood. So your kidney always has blood, and it goes through everything. You remember terms, the loop of Henle. So it filters, and then it drains down from the kidney through the ureters and then gets into the bladder. Now the bladder becomes a reservoir. You can hold the urine there, as everybody has a capacity they can hold based on your sphincter, based on your brain control. We discourage you from holding your urine. We teach you that when you feel the need to void, you do so. So know where the restrooms are so you can go. And then you'll see the bladder, and then you'll also see the urethra. For a male, it's a longer urethra because anatomically they have a penis. And for a woman, the urethra out right above the vagina, it's a shorter. And we'll talk about that. The shortness of that urethra in the female is what put women more at risk for developing a UTI, as well as other things. So again, this is a review, developmental factors. Someone asked me a question recently, and it was an excellent question when we talk about incontinence and babies. I thought it was a really good question. So we talk about, a baby, babies are born, babies, wet themselves. We expect that. Older, elderly people have an increased risk of having difficulty with urinating, but wetting themselves, it's not normal. It's a factor that can happen. So don't think that's something normal with everybody. You could have a 95-year-old person that still knows when they need to go to the bathroom, and and they can go. And your fluid and food, of course, water goes in, water comes out. If you're the person that drinks a lot of water all the time, then you definitely also go to the bathroom all the time. And there are other foods. A lot of foods have water, believe it or not. Fruits, vegetables, most plant-based products are also rich in water. By now, as a nursing student, you know about medications that can definitely affect your urine, and it's intentional. We give them these medications because we want them to urinate more, and that group of medications are diuretics. A most common one you may know of is furosemide, but there are others. There's Bumex, other diuretics, but furosemide is your most common one. Now, with regard to muscle tone, the bladder is a muscle, kidney is a muscle, but we talk about your muscle tone of your bladder, and also your sphincter, the strength of that sphincter can determine how well you can hold your bladder, and also whether you have control of releasing your urine, etc. Some people have some underlying pathological conditions that may affect their urine, as well as surgical and diagnostic procedures can either interfere with the urine as a consequence, or perhaps it's deliberate. They use the surgical and diagnostic procedures to find out what's if you have any alteration in your urinary pattern. So what does normal urine look like? On this slide, you'll see I have 1, 2, 3, 4, 5 different shades of yellow. The lighter, the top 3 are what normal urine should look like. And probably the third one is what your book may describe as straw colored. Now, for most people, when you look at your urine, remember that you're hopefully voiding into your toilet bowl. There's water there already. So that water is already altering what the color looks like. So I encourage you to start taking a look at your urine and just see what it is. Your water intake determines what the color will look like. So if you're an individual that drink your 8 glasses of water a day, it should look in the normal side, providing you're eating foods and other things. But if you decide to eat a gallon of water and drink more water in a quick time, then expect that urine should be on the lighter yellow. I've seen people's urine much lighter than that. The darker the yellow is a term we call more concentrated, meaning you do not have adequate water, or your kidneys not filtering it well. So you may have an issue with the fluid balance, and what's coming out is something that looks really, really concentrated. So as a nurse, you can look at a person's urine and you can draw some conclusions. Of course, you need lab data, urine data to a bit more to make a decision. It's not just the physical components, but just looking at your patient's urine, if it's left in a urine bottle at the bedside or in the commode, you can draw some conclusions from it, which will prompt you to ask the patient more questions. Okay, ma'am, or if she says her name is Miss Thomas, when I helped you at the bathroom, I noticed that your urine, the color was really, really dark. Tell me how much water you've been drinking. And the patient may tell you, oh, I haven't been drinking any water. So then you can talk about planning and intervening to help the patient have an adequate intake. Therefore, their balance will also be adequate. Let's talk about some terms that you should look up, and to memorize, I guess. So what the first one here is anuria. So this is when a person is not passing any urine, and it does happen. Sometimes it can happen with an acute event, or more common with a chronic renal issue, such as somebody who has end-stage renal disease. And you learn about that when you talk about kidney failure. So anuria is when a person no longer passes any urine. Polyuria, well, the word poly means plenty, so polyuria is when a person is passing a lot of urine, and you've learned that in diabetes as one of the signs of diabetes, polyuria. So someone, based on what they tell you with their urine, might make you be suspicious enough to ask them other stuff about their eating and drinking and eating as well, and find out perhaps them telling you that they urinate a lot of urine could be a sign that may need to be evaluated. Perhaps it could be for diabetes. Dysuria is any discomfort or pain with urination, and nocturia sounds as the word like nocturnal, urinating more at night. Other issues with urine is retention. You could have retention of your urine. It could be an issue with infection, could be an obstruction, could be something neurological. So whereas retention is holding on to the urine, incontinence is having no control of the urine or little control of the urine. And there are different types of incontinence. I put stress incontinence on this slide as a common one. Happens a lot with pregnant women because of the baby in the uterus is pressing on the bladder, and that pressure makes it makes the pregnant woman do two things. Frequency is another term. She may go to the bathroom frequently, but not necessarily passing a lot of urine, and then sometimes some of the urine may come out. Some of you might have experienced stress incontinence. You cough, you're sick, and you're coughing a lot, and you find that you may soil yourself. That's stress incontinence, and there are things that can be done to do that. One of the main things that people are taught is to do something called Kegel exercises, which is the exercise is supposed to help you strengthen the bladder tone. So I suggest that you look that up and find out how to do a Kegel exercise. So how to begin? You start with your nursing assessment, and as with all assessment, you want to start with a broad question. Ask the patient to describe what a normal day is with relation to their urinary pattern, and then after that you may ask them some specific questions. How many times do you go? How much do you drink? Are you on any medications? And specifically ask questions on, say, diuretics, and do your assessment, any complaints of tenderness, assess the bladder. One thing that you should understand, when a bladder is empty, meaning it has no urine, you really shouldn't palpate. You shouldn't really feel anything. It's pretty flat. If you palpate above the suprapubic bone and the patient complains of some tenderness, or you could feel something, that means there's urine in it. So that's just one a trick too. Perhaps you could try that. You can do that assessment on yourself. When your bladder is full, just try to palpate above your suprapubic bone and get a feeling of what the bladder may feel like when it's full. And you're also going to take a look at urine and to see what the urine looks like. You know, most of us, go to the bathroom and we flush it so fast. But I suggest that you start to take the time to look at your own urine, so you're familiarized with, what you eat. If you notice you went to the bathroom and your urine is pretty light color, you can say, oh, well, I've been drinking a lot of water, trying to be healthy, etc. Diagnostic tests can help do just that, diagnose some problems with urinary. Okay, so let's transition to a term that we talk about, a catheter. So when you talk about catheterization, you can put a catheter in many different orifices. So here we're talking about a catheter that's going to go through the urethra on the left side in A. It's an image of a woman, as opposed to on B where it's a male. And this is a good slide to show you the length of the urethra. So if we start on the top where where the bladder is, you can see the urethra is pretty short. So for the female, that puts her at risk for an infection. Whereas a man, his penis, regardless of how he's blessed in his DNA, the urethra is longer. And there's some issues with catheterization. So let's talk about that. Indications for a catheter. So a catheter, it's a rubber tubing with an opening at the top that goes into the urinary bladder to collect urine. The procedure to do it, it's a sterile procedure. So this is sterile technique. For most fundamental students, it's not a critical element or a skill, but it could be for subsequent semesters. I encourage you to look at videos on catheters. But whether you're putting the catheter in or not, you're expected to understand what it is. So we talk about two catheters. A straight catheter is a catheter that's placed into the bladder to collect urine, to empty the bladder. So it goes in and it comes back out. An indwelling catheter is a catheter that you leave in there to collect urine over time. You may have somebody who comes in with some super duper fluid balance issue, and they're not being hydrated with a lot of IV fluids. And one of the best ways to monitor to make sure that we know what goes in comes out in almost equal parts is the patient may have an indwelling catheter. However, catheters cause problems. One of the main problems with the catheter is something you'll hear healthcare people call CAUTI, catheter-associated urinary tract infection. Basically, we gave it to them because we put the catheter in. So it's considered one of these nosocomial, hospital-acquired infection. CAUTI is one of them. Of course, there are others. And one of the main reasons that they may get it is from the point of insertion. Perhaps the individual broke the sterile field. It wasn't sterile and it wasn't done properly. Other part is improper catheter care. Bacteria getting in because perhaps someone who's emptying the catheter doesn't use the right technique. Use the same gloves from patient to patient. Trauma, pulling. The body, it's an altered system. You are not born with a catheter. So your body's adjusting to that. So CAUTI, catheter-associated urinary tract infection. It's an infection that happens in the hospital. It costs the patient, it impairs their health, and also causes cost hospitals money from the care from it. So if it's an indwelling catheter, and some of you may call it a Foley catheter, you should understand Foley care, asepsis, maintain patency. check for kinks. If your patient who has an indwelling catheter is complaining of abdominal pain, you should definitely go and assess, palpate above the suprapubic bone to see if the bladder is full. If the client has an indwelling catheter, the bladder should never be full because it's draining by gravity. So if the bladder is full, there's something not going on with the catheter. Make sure the catheter is not kinked, it's not bent. Another thing that you use to help minimize it from being irritated is to secure the catheter on the inside of the patient's leg, and make sure that you put the collection bag, on a solid surface. So again, just like when you do with restraints, you want it on a solid surface on the bed so it does not move. So again, look up some other videos and in your text, your resources on catheter care and how you, as a nursing student and a future nurse, can minimize a client from getting a catheter associated infection. Here's another type of catheter. We call this a condom catheter. As you see in this picture, this is a mannequin, and it goes on similar to a condom. So in this one, on the bottom, it has an opening, and that gets attached to a bag. So a less risk of infection because it's not inside the bladder. It just covers, for the male, it covers the penis so it can collect the urine. And you wonder why they would do that. You could have an individual who's incontinent and they also have a bed sore, and every time they urinate, the urine may go into the bed sore and impairs its healing. So this condom catheter on the outside can collect the urine either to what's in this picture, a leg bag, or we could even have it go to a bag just the same way we would have an indwelling catheter. So a condom catheter, it's external, and because it's external, it minimizes the risk than say from an indwelling catheter. So this is another option that can be used. Let's talk about collecting a urine specimen. So I have two listed here, but really three. So one of the main ones that most of you probably have had done was a urinalysis. So when we're talking about collecting urine, a urinalysis it doesn't have to be sterile. That's important. We're going to talk about the term clean catch, but a urinalysis does not have to be sterile. A urinalysis can tell you quite a few things. It can tell you quickly if there are ketones, and ketones in the urine, it's important, especially if the person is a diabetic. If they're on some super duper high fat diet, their urine may show ketones. You can see the color. It can tell if there's any bacteria, just briefly. It can tell if there's any blood. It can tell the specific gravity, and you learn the specific gravity. The normal specific gravity is like 1010 to 1030, 1.010 to 1.030. So I just call it 1010 to 1030. The lower the specific gravity, it's usually more dilute urine. The higher the specific gravity, it's a normal to then more concentrated urine. So that's on a urinalysis. A urine culture. Now, when you hear the term culture, you're not talking about trying to identify a bacteria. So if you want to do a urine culture, you want this to be a sterile technique because you don't want the bacteria that's already down in the perineal area. You want to find the bacteria that's in the actual urine. Now, this is part I think that sometimes gets students confused. So I'm going to try to explain this as best as I can. It's the same clean catch technique that's used to get from a patient who is alert and can follow commands. So to instruct the person to make sure the perineal area is as clean as possible, start to urinate and let some of it drop in the commode, and then put the collection cup in the middle to catch it. That's what we call a midstream clean catch. Now this is for a person who has control over their bladder, so you can use that. If the person does not, or they're incontinent, or they're unable to follow instructions in that way, then you may have to use a straight catheter with a sterile technique to get that urine specimen. Now, if your patient already has an indwelling Foley catheter, you can actually get the urine specimen from that little port that's on the top. Real key here, do not collect urine from that bag on the bottom hanging on the side of the bed for your sample. When your client has an indwelling catheter, the urine is collected from that port that's right at the top where it's usually connected to the catheter itself and the drainage bag. Lab values. So on this slide you see some normal lab values that from urine. There's a pH, the color, amber straw, specific gravity here 1010 to 1025, some says 1010 to 1030. You can check if there's protein, you shouldn't have any. It says glucose, you shouldn't have any. Ketones, you shouldn't have any. Just very, very few red blood cells. Whenever you send you look at a urine sample, and if you ever see it says red blood cells, you want to ask the patient, especially if they're female, of course, if they're female, ask them if they have their period, if they're menstruating, maybe one or two cells might have gotten into the urine. So, but normally you shouldn't have any red blood cells in your urine. So there you have it, ladies and gentlemen, a few slides, a brief video on elimination. I hope you can use this to supplement your reading, learn how to assess normal urine, a normal urinary pattern, understand some of the abnormal terms in order to determine when to make a referral, to give your client instructions, when to intervene. And as always, if this is your first time to my channel, welcome. I hope you stay. Have a good day.